this large room. There's still some spaces, so we'll pull up shortly. We're here today to kind of have a celebration of Muhammad Al-Maged's journey in academia and scholarship. And so we're here to listen to him defend his topic. And at the end of the day, we'll have his committee approved, and we'll start the next stage of the journey, which we all know is going to get all of this research information down to institutional review board, and then start the data collection process and go from there. So Muhammad is quite an accomplished young man. He graduated from the University of Cairo with his Bachelor of Physical Therapy degree in 2003. He graduated with honors, which doesn't surprise me a bit. He practiced some of the top scholars to our programs. And that was in 2003. And in 2009, he got his master's degree from the University of Cairo as well. And after he received his master's degree, he went on to do some teaching in the orthopedic section at the University of Cairo. So we're pleased that he's chosen an orthopedic topic to defense. In 2011, he had the opportunity to present one podium presentation and two poster presentations at the World Confederation of Physical Therapy conference. And that was in the Netherlands, and so that was very impressive. And so he certainly has done something I've never done. And in 2 weeks, he'll be presenting a poster presentation at the Combined Sections meeting in Las Vegas. I know that many of the faculty will be attending, and some of the students will be attending, so please take time to stop by and visit him his poster and spend some time learning about more information on the wrist and hand. He also has 5 publications, so oftentimes publications come after your research-oriented degree. In this case, Muhammad already has 5 publications, primary on one and secondary author on others. And this came from some of the research that he did on the wrist and hands while working on his master's degree. So this next presentation the presentation that we're giving next has always been a dream of his, and it's a continuation of what he learned and studied in his master's program, and then he's enhanced that here at Loma Linda. He is quite good at making connections in the community, and he has already reached out to some real experts in the wrist and hand in the community, local and global, and so he's going to bring that to his project as well.
Thank you, Dr. Moore. Good morning, my dear colleagues and professors. Back in 2009, I presented a topic about distal fractures, and that was my thesis presentation. Distal fracture was one cause of radial side wrist pain. Hopefully today I'm presenting about ulnar side wrist pain. So hopefully by completing this degree, I think I can cover this area. So my topic today is about ulnar side wrist pain, and the topic title is Linking Physical Therapy Outcome Measures to the International Classification of Functioning in subjects with ulnar side wrist pain, particularly subjects with triangular fibrocartilage complex injury. I'll explain this in details in a minute, but let me first welcome you to the Centennial Complex and to the room 3111 that we are in right now. The reason I brought this up, this is not the original picture actually. When I googled Centennial Complex, this is what I got. I found Dr. Bowman teaching this class. Probably this is a cervical spine class because of this large binders you gave us. So I just photoshopped you and edited myself over and over. So I can students smiling at me as well. Anyway, today I'm going to talk about the physical therapy after the triangular fibrocartilage complex and ulnar side wrist pain. And then I'll try to link my outcome measures to the International Classification of Function. And finally, I'll try to develop a clinical prediction rule that guide the clinical decision making in subjects with these injuries. So first, let me give you a hint about the ulnar side of the wrist. The ulnar side of the wrist has been referred to as the black box of the wrist because of its overlapping structures and complex anatomy. Its injuries has been compared to those of low back pain. And one important structure in this area is the triangular fibrocartilage complex, located here between the ulna and the ulnar corpus. The triangular fibrocartilage, as its name implies, is triangular in shape, located between the ulna and the ulnar sulcus, and it's attached to the ulnar steroid process to the sigmoid notch of the radius. This is the #1 source of the ulnar side wrist pain. Other common sources include lunotriquetral ligament injuries, ECU tendon, extensor carpi ulnaris tendon subluxation, and tendinopathy. Because of the morphology of this structure, it makes it resembles the knee meniscus. That's why some authors refers to as the wrist meniscus. So this structure is a congregation of ligaments, fibrocartilage, and articular disc. It consists of articular disc located here called the TFC proper, the volar and dorsal ulnar ligaments, the ulnocarpal ligaments, and the ulnar collateral ligaments here, and the tendon subsheath of the extensor carpi ulnaris. Because of this structure is triangular in shape, and it also has a peripheral circulation that resembles a knee meniscus in terms of the peripheral part is vascular, the central part is avascular. So it mimics the knee meniscus in terms of morphology, blood supply, and even the mechanism of trauma. This structure acts as a cushioning and stabilizing surface to the other side of the wrist. It allows smooth transmission of the load across the other side of the wrist. As we know, that 20% of the upper limb load is go to the other side of the wrist. This structure allows smooth transmission of the load and also allows smooth supination and pronation. Also, Tang et al. In 1998 found that this structure acts as an important pulley for facilitating the action of the extensor carpi ulnaris tendon. Removal of this structure has found to increase the tendon excursion by 30%. Balmer in 1989 described a classification system for the kind of injury of the triangular fibrocartilage complex. The injury is categorized into either traumatic or degenerative. What we care about here is the traumatic causes of pain. So we have 4 types of traumatic injury. Type 1A is central perforation of the complex. Type 1B is avulsion from its ulnar attachment. Type 1C is avulsion from its distal attachment from the ulnocarpal ligaments. And type 1D is avulsion from its radial attachment with or without sigmoid notch fracture, which is radial attachment. In examination, we have to assess for stability of the distal radioulnar joint and for extensor carpi ulnaris tendon. This is a handful player I assessed back in 2010, and he had a TFCC injury with ECU tendon subluxation. It's a short video, I can show it to you. Here you can see the dorsal subluxation of the ulna depicted by avulsion of the TFCC complex here, which is supporting structure, and you can see here the gliding with a click of the ECU tendon over the distal ulna. If you can listen closely, actually you can hear the click of the tendon gliding over the distal ulna. So the examination is straightforward by clinical presentation of the pain at the ulnar side of the wrist, and it's confirmed by some valid and reliable clinical examination, like the ulnar fovea sign, which has high sensitivity and specificity for the diagnosis. Also, the palpation of the ulnar snuff box. This test is analogous to the McMurray test of the knee, which its name is TFCC grinding test, which we are grinding the structure over the ulnar side of the wrist to provoke the symptoms. And this test has a 100% sensitivity for detecting ulnar wrist pain due to TFCC injury. The diagnosis further confirmed with the use of imaging techniques. Traditionally, the magnetic resonance imaging, the MRI, has been used as the traditional standard method of diagnosis. But due to our limited resources and due to the availability of the ultrasonography in our department, we will choose to diagnose the patients or with subjects with ulnar wrist pain with ultrasonography. And Dr. Lohman just told me that Dr. Petrovsky agreed to borrow ultrasonography from his lab, so we can use it for diagnosis as well. We have supporting documents for use of ultrasonography in diagnosing of ulnar wrist pain. In 2006, the APTA published a treatment approach, which was evidence-based, outlined the criteria for management of subjects with wrist and hand fractures or wrist and hand injuries. And this is from a book called The Bible of Hand Therapy. It's the rehabilitation of the hand, published by Moss in 2012. In chapter 70, Dr. Lasseter proposed an algorithmic treatment approach for subjects with triangular fibrocartilage complex injury. And in his approach, he categorized the causes of pain into 5 categories. What we care about here is these 2 categories, the tendinitis and the TFCC articular test. The main treatment was the splinting and strengthening, plus or minus strengthening if the patients can't tolerate the strengthening exercise. So basically this is what I'm going to do, as I'm going to explain in the methodology in a bit. But what I'm going to do in this study, I'm going to use the splinting and strengthening exercise. So now, one area we want to study in this research as well, we want to link our outcome measures of physical therapy to something that is standardized and valid. The ICF model, the International Classification of Function, is a conceptual framework on which I built up this research. As you know, historically, the physical disablement model has been evolving through the years, from the Nagy model in 1960 to the ICIDH in 1980 to ICD-9 and ICD-10, and then the ICF, the International Classification of Functioning, Disability and Health, proposed by the WHO at 2001. In 2001, the WHO proposed this model of functioning, and it has 3 main domains: body structure and function, which can be impaired; participation, which can be restricted; activation of activity, which can be limited. What's unique about this model, that participation restriction and activity limitation has replaced previous terminologies like disability and handicaps, which decrease the negative connotation implied by these terminologies. Unfortunately, the Medicare system doesn't reimburse for the ICF codes right now, but with direct access legislation proposed in California in 2014, we hope in the near future that Medicare can do this. So, clinical research have attempted to focus on how the ICF might predict the health outcomes in subjects with different conditions, like rheumatoid arthritis, osteoarthritis, different musculoskeletal conditions in different phases of rehabilitation. In 2009, the WHO released an brief ICF model for hand condition. It's called the brief ICF course sets for hand condition. And this course sets I'm going to use in this research. In this study, Dr. Scuteri et al. 2010 applied this brief ICF model to subjects with distal radius fracture. Their outcome measures was the patient satisfaction score as measured by the Michigan Hand Outcome Questionnaire. After 6 weeks, they found that the personal factors of the personal domains of the model predicted 19% of the variability in satisfaction score. Activity and participation domain predicted 65%. Body function domain predicted only 6%. In 3 months, after 3 months, the personal factor predicted 9%. Activity participation predicted 80%, body function predicted 8%. They concluded that the ICF can be used to reflect patient satisfaction over time in subjects with distal radius fractures. Because the ICF is a classification system, not a health measurement system, we need to replace its domain with a quantifiable variable so we can get an idea how to link our variable to the classification system. So in this study, for example, Harris et al. 2005 linked the ICF to subjects with distal radius fracture. They used the short form 36 questionnaire to represent overall health. For pain, weakness, loss of dexterity was used to represent impairments in body structure and function, and they measured using risk outcome measures and patients rated risk evaluation pain subscale. Difficulty in doing tasks was used to represent activity limitation and was measured using the patient's rated risk evaluation specific activity subscale. Restrictions in participation restriction was measured using the patient's rated risk evaluation usual activity subscale. After 3 months, they found that the patient's rated risk evaluation questionnaire predicted 33% of the change of the 36 questionnaire, and after 1 year, the PRWE predicted 28% of the SF36 questionnaire, and they concluded that the ICF provide an insight is a useful frame in determining health status after dystorelia fracture. So based on that, this is my proposed ICF model applied to the ulnar side wrist pain. I'm going to measure the total health outcomes with the short form 36 questionnaire. Pain and range of motion strength impairments will represent body structure and function impairments, and they will be measured using the pain subscale of the patient's distal evaluation, the goniometer, and the jammer dynamometer. I'll explain this later in the methodology. For difficulty executing tasks will represent the activity limitation domain, and they will be measured using the specific activity subscale of the patient's rated risk evaluation. For the restriction in work social recreational activity will represent the participation restriction, and they will be measured using the usual activity subscale. So these measures will be linked and correlated to the short form 36 questionnaire. Let's now move to another area I want to investigate in this study, and it's so important. Why? Because it's guide a clinical decision making in terms of how we're going to use this modality with different kind of patients. So we used to rely on empirical research and experts' opinion, but clinical prediction rule is a way that we can quantify the variable contribution to the success of treatment, and so we can have a consensus toward a treatment in certain conditions. So my question here, can we derive potential predictors that guide clinical prediction in subjects, will guide the clinical decision making in subjects with ulnar side wrist pain? To do that, we have to apply the clinical prediction rule. And the clinical prediction rule, we have three phases. First, we have to derive our variables that we think it might predict and will help predict the outcome of the treatment. And then we validate these variables in different settings, and then we analyze its impact on different health status. Clinical prediction rule has been attempted in different areas of the body, like neck pain, femoral pain, tennis elbow, but never on never on the ulnar side wrist pain. So, for example, this study, Dr. Menken and Leland, 2010, tried to develop a clinical prediction rule for subjects with shoulder pain likely to benefit from cervical thoracic manipulations. And the outcome measures were 50% reduction in pain severity and score of 4 or more on the global rating of change. After the statistical analysis, they came up with these 5 variables, and they documented that the presence of 4 or 5 of these variables will result in 100% probability of success of the treatment. Presence of 3 of these variables will result in 89% of the success of the physical therapy treatment. So, I'm not gonna reinvent the wheel. I'm gonna do the same. I'm gonna derive predictors from my clinical exam, from my history, from variable like age, gender, activity, and duration of symptoms, from tests like the one that I showed you in the video, the Bianchi test, the ulnophobia sign, the ulnar stress test, and the score I'm getting from the patient's rated risk evaluation. And then I'm gonna use the ultrasonography to sort patients into either having TFCC, unitraquetral ligament injury, or ECU tendonitis. That being said, we have 3 purposes for this study. First, we need to investigate the effect of splinting versus splinting combined with strengthening in subjects with ulnar side wrist pain. And then we'll try to apply the ICF, the International Classification of Function brief model, to the physical therapy outcome in subjects with ulnar side wrist pain. And then we'll try to develop a preliminary clinical prediction rule that guide the clinical decision making in subjects with ulnar side wrist pain. And secondly, we have 3 research questions. First, will splinting compared to splinting combined with strengthening will have an effect on pain, function, range of motion, strength in subjects with ulnar side wrist pain? Can we apply, or can we use the brief ICF model to predict health outcomes in subjects with ulnar side wrist pain? And what are the clinical predictors, potential predictors of treatment success that guide our clinical decision making in subjects with ulnar side wrist pain? So this is a prospective randomized controlled trial in which we are targeting 60 subjects. Their age will be ranged from 18 to 50. We choose 18 to ensure full skeletal maturation and not beyond 50, not to have subjects with degenerative causes of pain. Subjects will be included in this study if they have ulnar-side wrist pain due to triangular cartilage complex injuries, ECU tendon subluxation tendinopathy, and or lunatoid ligament injury. They will be excluded otherwise. After the informed consent is obtained, subjects will be grouped into one of the three treatment groups. Group A will receive splinting for 4 weeks. Group B will receive splinting and stenting for 4 weeks. Group C will serve as a control. My evaluation will be at baseline, 2 weeks and 4 weeks of the treatment of the start of the therapy. My outcome measures will be strengthening measured by the JAMR dynamometer following the guideline described by the American Society of Hand Therapy, 1992. Pain and function will be measured using the patient's rated wrist evaluation questionnaire. For range of motion, I'm going to use the universal standard galiometer for measurements, and for overall health, I'm going to use the short form 36 questionnaire. And we're going to use also the ultrasonography to discriminate our subjects with the 3 intended pathological symptoms. So these are my questionnaire. The patient's rated wrist evaluation questionnaire is subjective self-reported questionnaire. 5 questions addresses pain, 10 questions addresses function. We have a score from 0 to 150. 0 indicate asymptomatic subjects. 150 is a subject with complete loss of function and severe pain. The short form 36 question, and this is part of the questionnaire. It's a generic health outcome measurements and has 36 questions addressing different aspects of health, like general health, social health, emotional status, physical and mental aspect of life. My intervention will be splinting. I'll use the ulnar gutter splint or the VZ4 pulse splint. Strengthening will progress from supination to neutral to pronation if there is no pain. Again, following the guideline described by the American Society of Hand Therapy and Dr. Lassiter recommendation 2002. For the statistical analysis, I have 3 research questions. So, first research questions, I'm using 3x3 mixed factorial ANOVA to investigate time by group effect. We have 3 measurements time and we have 3 groups. If there is significant difference between groups, we're going to do post hoc analysis using Confironi correction. Significance level will be set at 0.05. For the second research questions linking the ICF to my outcomes, I'm going to do correlation and regression analysis. And for the third one, the clinical prediction rule, we're going to calculate the sensitivity, specificity, positive likelihood ratio of our potential variable, and then the variables will be entered into a regression equation, regression analysis. To further elaborate on this one, after we obtain the data from the baseline and do our intervention, we're going to dichotomize subjects into either having successful versus non-successful treatment. And then we're going to compare our potential variable across the groups. We will use t-test for continuous variable and chi-square for categorical variable. Some variables with clinical significance, statistical significance will be re-entered into a regression analysis to further analyze and predict the clinical or predict the outcome to come up with the potential predictors that guide the clinical decision making. Before thanking you, I'd like to invite Dr. Lohman and Dr. Noah and Dr. Said to participate in this research as a supervising committee, and I hope that I can finish this work before my scholarship ends.
Do you have any questions, Mohammed? Statisticians are happy?
No questions.
Wow. Well, okay. I have a question. We do have questions.
Very nice job. I want to just make a couple of comments. One, first I just want to recognize Dr. Lohman. I think the introduction that you gave was helpful in just gaining insight into his background. That was helpful for the group. Your sample size is going to be 60 subjects, 3 groups of 20. 1/3 are going to be a control receiving sham, but they will be patients, correct?
Yeah.
And so I'm just wondering, will they have an opportunity at the conclusion of the study to come through any of the treatment protocols?
This is actually what I'm going to do after I take the 3rd measurements at the 4th week. I'm gonna re-recruit the subjects into the clinical
Into that,
prediction group,
okay.
so we have the treatment again.
Great. A couple other just minor questions. There's a certain standard measure of error with goniometric measurement. And
Yeah,
I
we
just wondered
have
if you have a plan for reliability, inter-tester reliability.
Yeah, the jammer, the note is already valid and reliable, and we have reference value for different age groups.
Right.
So I'm gonna just use the values to get an idea about what I'm gonna get in the examination. But I'm gonna record whatever I have in the examination.
And then this final question pertains to blinding. Are you going to have measurements taken by a blinded researcher?
This is what I'm intending to do. I'm hoping that I have two therapists, Dr. Luman and another person to help me in blinding. So neither the subjects or the therapist doing what's going on, so we can have more valid stuff.
Thank you.
You're really not going to be able to blind the subjects because maybe the controls with the sham might think they're getting the treatment, but certainly the other two groups are going to know whether they're getting exercises or whether they're just getting this blend.
Probably, but because of the nature of the study, yes. But I'm intending to do a sham for the control and the blind splint over the elbow. So they may think that they will receive the treatment because it's in the same area.
Right.
But for the I may not control for blinding in other two groups. You're right.
And sometimes you just can't.
Yeah, because of the nature of the study.
Yeah, the more important thing is to have the person who's assessing be blind for the group.
Yeah.
Thank you for that explanation. I have one more question for you. What is your work using the ultrasonography?
Sorting subjects into either having PCU tendinitis versus TFCC versus unicular ligament injury.
And are those ones going to be acute, subacute stage, or what stage?
Well, actually, I'm looking for post-traumatic. So they're gonna be after the usually after the activity, after the injury has happened. But if they can later, we can check the eligibility. But for the pain, we're recruiting subjects with on-the-side wrist pain. For the clinical prediction rule, we need the subjects with on-the-side wrist pain. So this is what I'm intending to do. Just doing the physical therapy examination at any time of the any time of recruitment, and then find out, sorting out after statistical analysis, which subjects benefits more. And this is going to be my potential value as well.
What is the feasibility in recruitment of 60 subjects?
This is another point. Yes, thank you for asking. Dr. Loman referred me already to the East Campus, the hand clinic over East Campus. I went through some files, I got an idea, and I found out that there is a doctor, MD here in Loma Linda, who's #1 source of referral for many subjects of on-site wrist pain. So I contacted him, he didn't respond back, but hopefully he can direct me. I was about to include him in my research committee, but he didn't respond back. So I'm just trying to help. I have just like one and a half year for doing this research. So probably if I'm getting subjects within a year, it's gonna work for me. But if I don't, I will not do the clinical prediction rule. I'll do just the first two questions, the ICF and my intervention on the subjects.
That's a good plan.
Yeah, this is what I was planning with Dr. Loman because 60 might not be feasible over this time.
Thank you.
I might also want to add that he's contacted the Rancho Group, which has over 50 some clinics, specifically on Riverside, we go back to I think therapists, they're willing to help, and also the Human Center of this campus. So that was my point, that he is very good at reaching out to the community and soliciting support.
Yeah, it was one of my plans, but I didn't do it. I will. Yeah, please.
I think you've exhausted the questions. Well, I'd like to thank all the students and family and friends that came out, as well as faculty. This is certainly an important milestone for our students, and without you, it would not be as special. So we appreciate you coming out. And you're also serving as a beautiful role model for students that aren't quite as far as this journey. And so the bar is always set so high, we don't want it to be daunting, as everybody as possible. So thank you so much. committee will step out. This room is yours until 10 till the hour, when I believe another class will be coming in. So thank you so much. I'm just gonna step out just for a second. Talk to you. Come back. Hey, Chairman.